Hello and welcome to Pain in the Podcass, your place to find out everything you've ever wanted to know about pain. My name's Dr. Joseph Parsons and I am joined by the wonderful Don Widgesoria and Dr. Joshua Craw. And today we're talking about the NHS crisis, part 2. Welcome in. Hello everyone and welcome to part 2 of our episode on the NHS in crisis. You might remember that before we were talking about kind of the situation that the NHS is in. We were talking about things like understaffing, some of the reasons why we struggle to recruit people or retain people in the NHS. And this episode we're going to talk a little bit more about what some of the potential solutions might be. We hope you enjoy.
And so, speaking about all this, obviously all of this, and anyone listening to this is not naive enough to think otherwise. All of it boils down to money, right? It's not as if anyone sat high up in government is thinking, you know what, I'd love to provide worse quality healthcare. Like, everyone ideally wants the highest quality of healthcare, but it's the money that's the issue. So, what sort of things can be implemented to save money, both that seem positive and that seem negative? What things are being done to try and save money?
Well, we could tax the rich.
What?
Yeah, so, for example, medicines. We can optimise the cost of medicines. So, working as a conglomerate like the EU, for example, we can get lower costs on medical supplies. So, if we compare, for example, the United States, which is very poorly regulated in this aspect, and each hospital has to effectively say, oh, I want to buy paracetamol, I want to buy ibuprofen, I want to buy antibiotics. They all have to pay higher fees because they're not working together. Yeah. Whereas the NHS, we can get things cheaper.
Nice.
Do you know how much? Have you heard of fentanyl, like the really strong opioid medication? We've got a little. I'm working in anaesthetics at the minute. We've got a chart and it tells us the price of everything. How much do you think one vial of fentanyl costs?
25 quid.
Okay.
I'm going to say 45.
Pounds?
Yes.
Okay. 14 pence.
Wow.
So, like, if you used to get that in America,
it might be 25 quid.
It could very easily be 25 quid. That's how much the charge
Fentanyl is
patients.
14 pence for a little vial.
For a vial, yeah.
Is it in a glass thing?
Yeah, a little vial, a little glass
ampule.
vial.
An ampule.
Wow.
You break the top off.
Surely the ampule itself is worth more than 14
Yeah, I was going to say.
It's probably like a penny, isn't it? I don't know.
What?
On that bulk, I guess. It's the mass production.
It is the mass production, and it's because the NHS is such a behemoth of a institution. We can buy things in such bulk that we can get those prices.
Okay.
So if we can optimise that.
Yeah.
When I used to play darts, I worked with a gentleman that his entire job in the NHS was trying to source cheaper things. So he would go between companies, have them play against each other to give us cheaper paper towels, for example.
Yeah, and he might get paper towels for 1p cheaper per roll, but when you translate that to all the paper towels that the NHS needs,
exactly.
Like, it's enormous savings.
It's like biscuits in the NHS. They're all Crawford's biscuits.
Yeah.
There's only 4 biscuits in the NHS. There's a ginger nut.
Custard
creams, bourbons, and those fruity ones.
Oh, is there not a digestive?
Oh, there's digestives and then fruity ones. 5 biscuits in the NHS.
What's the fruity one?
Like a
shortbready.
Yeah,
Oh.
I can't. The one.
The raspberry
raisin.
Oh, right.
Yeah, it's got a little. It's not a Garibaldi. It's not that good.
I like a little ginger nut.
Garibaldi, what a great name.
I know.
I've not thought about Garibaldi biscuit in about a decade.
Why is it called a Garibaldi biscuit?
Don't know. It sounds Italian.
It does sound
Yeah.
Italian.
Right.
Are you
going to
gonna look
I think there was somebody called Garibaldi, right?
Garibaldi.
It's not spelled. It's not spelled Gary Joe.
Josh is looking at me, noting down on my little notebook there. But also, sorry, about medicines optimization. So my wife is a pharmacist and she works in medicines optimization and doing things like looking for patients who are on unnecessary medications and changing branded medications for generics. Yeah. So if you imagine that you're going to buy Weetabix. Fairy Weetabix.
No, Fairy's a good one, though.
If you're going to buy Fairy Liquid and you get the...
Hold on, the Fairy might backfire on you.
Why?
Because Fairy is a lot better in quality.
But is it? It's not.
Okay, fine, Weetabix.
Yeah.
Right? You want to buy Weetabix and instead you buy the Wheaty Bic from Lidl, whatever they call it.
I love Lidl, but go on.
The costs are so much cheaper for the generic, and actually in quality it's the same. And obviously with medications there's that level of stringency, because I know sometimes the Lidl and Aldi own brand stuff isn't as good as the branded stuff, but in medicine you can't be like, oh, we've given them a bit of a shit version of a drug. Like, it is the same quality drug, It has to be maintained to the same standard. So changing people to a drug that doesn't have a fancy brand name on it saves a lot of money. It's the same as like Nurofen versus generic ibuprofen. It's like there's no difference in your ibuprofen tablets.
But it's Nurofen Plus.
That does have something else in, doesn't it? Caffeine.
I think it might have caffeine.
Something. But you know what I mean? The same pill.
Yeah, exactly.
With a brand makes no difference. And so if you can get it much cheaper, or even changing the size of tablet. I know that my wife was working on a project where a 200 milligram tablet, a packet of 200 milligram tablets was something like 15 quid or something, but a packet of 100 milligram tablets was like £1. So if you made people take 2 100 milligram tablets, it ends up being like several times more expensive than giving them the 200 milligram tablet. And so it's working out, okay, this sounds brilliant, but are there any patients on your list who maybe wouldn't take an extra tablet because they've got poor adherence to medications, or they've got a bad swallow, or, But actually, thinking about who it's appropriate to use it on, you can save a lot of money with simple things like that. And she does.
Yeah.
It's all thanks to her. The NHS is alive due to my wife. No, but there are a lot of teams out there. This is becoming more of a prevalent role within the NHS.
I think it's an important role, to be fair.
100%.
Yeah.
100%.
How about prevention?
Yes.
That is... prevention's cheaper than the cure, I think the saying goes, isn't it?
Absolutely. And the NHS long-term plan is moving towards, one of its key pillars is moving towards prevention and community care. So looking at things like obesity prevention, obesity costs the NHS about £58 billion a year. So if you imagine how, if we were trying more actively to prevent that, it might seem like a high cost for these interventions, but it saves a huge amount of money.
Yeah, and obesity is just such a growing issue.
Aha. That's a great pun. Thinking as well as prevention, like I said, we're trying to move into community care. There's something called hospital at home, which is basically provision of not quite the equivalent of hospital care. It's not the same kind of, you don't have the same level of staff supervision, but regular care coming in from clinical staff to look after you in your own home.
But it gets people out of hospitals.
Yeah, so less chance of getting infections.
The cost of acute beds.
Yeah, I mean, certain examples have shown that it can save up to £3,071 per patient per stay. If you imagine you've got a patient who ends up in hospital 3 or 4 times a year, and you can get them home quicker.
Wow. So it costs so much just to have the patient in the hospital, as opposed to visiting, as opposed to the doctor, the healthcare professional, whoever it is, visiting that person's home.
Yeah.
Precisely.
Wow, okay.
Yeah, so like if you've got somebody who's got a chronic lung condition and they're in hospital for an exacerbation of that, we can send them home with a nebulizer, so like that's like aerosolized medications to help with the breathing, and we can have a nurse go ring them up or go a couple of times, take some bloods, that sort of thing, see how they're getting on. Yeah. And rather than being in hospital, getting regular observations, using our medications, which cost us more, bish bash bosh, saving thousands.
And it's not just like hospital treatments as well, like telehealth generally, providing healthcare over the phone or over video calls and stuff, in the right circumstances can be a great opportunity to save money. So, for example, after hip replacements now, after a standard routine hip replacement, you'll get usually a triage call at 2 weeks where they'll basically ask how you're doing and ask you if you're able to do sort of specific movements and how you're coping, how your walk-ins go in, whether you're still using crutches, to work out whether they need to see you in person or not. And this scheme has saved thousands and thousands of pounds across NHS trusts because you're not seeing every patient routinely after these operations where they don't need to be seen.
I love this idea. Well, I guess it's not an idea anymore. But I love this. But what can I just ask? For the mobile network companies, can they recognise when it's an NHS number and just tell me that it's an NHS number instead of saying no caller ID or unknown number? Because I'm obviously not going to answer that. I just wanted to say GP or whatever, and not miss my call.
Yeah,
because I'm always paranoid that I'm going to miss it.
To be fair, one of my friends is a teacher, and whenever I get a call from him, he's obviously withheld his number, so if he has to
Yeah.
call kids' parents and stuff, so it just says private number, and I'm just like, okay, I suppose I'll answer it. But sometimes it's not him, sometimes it is a
Yeah.
scam, so
Yeah.
it's a bit like it's...
Then you pretend to be an Alaskan crab fisherman.
I do.
That'll be in the breakdown.
But thinking about the cost savings as well, so all of these that we've spoken about then are quite positive cost savings, but the one that we seem to be seeing the most at the minute is freezes of staff recruitment.
Boo!
So does that mean stopping applications coming in or
Stopping
stopping hiring?
Stopping hiring.
Cool.
So it's... I know, for example, that when I was qualified as a physio and was looking for jobs, within 30 miles of my house, over the course of a 6-month period, there were, I think, 4 jobs that came out. And bear in mind, in that area, there are hundreds of new graduates applying for the jobs. So it's like, I feel very privileged to have got a job, full
Yeah.
stop, even though the commute is pretty terrible. But, you know, it shows you, like, places just aren't hiring at the minute because they feel it's cheaper to cut back on staff recruitment. And like I said at the beginning, if you can show that you can cope with a smaller staff number, then they will expect you to cope permanently. So actually, in the nicest possible way, and obviously I'm not suggesting anyone give poor quality patient care.
Do your jobs
but bad
badly.
things happening, like where patients are receiving inadequate care, as awful as that is, and you don't want that, but it actually highlights that services aren't being funded well enough.
Maybe it could just be little things like using too much blue roll and
Having
eating
an
too much
extra biscuit.
biscuits. Yeah.
And extra fentanyl.
Yeah, helping yourself to a buffet of fentanyl.
Fentanyl and biscuits. It's crippling the NHS. But you know, that's it. It's a little bit like if you just buy a new kettle and stop eating avocados, then you can buy a house. That whole thing that was going on in 2022 or something with Boris Johnson and who was the person who said about the avocados?
fuck? Buy a new kettle and stop eating
Avocados.
free
and you'll be able
shavacadoos.
to- Yeah, you'll be able to afford a house apparently.
Okay.
Boris Johnson was like, you can save £10 a year on electricity if you buy a more efficient kettle, failing to realise that the new kettle is more than £10. But who was it that said about the...
It sounds like something you would say.
Someone said about stop eating avocado toast. Was it Katie Hopkins?
Oh, there's loads of people that say that. It's almost a meme at this point,
It's a
isn't it?
boomery thing, isn't it?
Have you tried not getting coffee? Have you tried not fucking me off?
This is a controversial one, but it's just something that came into my head. I feel like when it comes to paying for prescriptions, I think for most people they have to pay nowadays.
Majority, yeah.
Yeah. How much of a help do you think it would be to the NHS if people paid just a little bit more for prescriptions, depending on what that was? If there was a way to kind of structure it so that medications under a certain cost did have to be paid, whereas medications over that cost did not have to be paid by the user, by the patient.
So you're saying people with conditions where they have to pay lots and lots of money for drugs don't have to pay the upcharge, but
Yeah.
the cheaper ones
The
do?
cheaper ones, yeah.
I mean,
So that's just my thinking there was to address stuff like the common cold or whatever, these silly things that people seem to go to the A&E for, like hiccups, like charging for
I
that.
just shout boo at them.
Boo. But yeah, that was my thinking.
I mean, this harks back to the episode we did on paracetamol, doesn't it? It's getting a prescription for it just costs the NHS so much more, and no one really wins. The patient could get it quicker and cheaper if they get it from a shop.
Yeah.
So it's, there's a balance to be had, and I don't necessarily think that upping prescription charges in certain cases would make a massive difference to the NHS. I think there's just some areas in which we chronically overspend, such as like not
Biscuits.
optimising medications, biscuits.
But those biscuits are essential.
It's
Yeah.
really cute. When I went to visit my nieces in Australia, and this is something that they've learned from Bluey, but whenever something bad happens, they just say, "Oh, biscuits."
Oh, that's really cute.
That's so cute.
That's what West Streeting says. Every time there's a doctor strike. Oh, biscuits.
I think you might use a few more choice words.
Yeah.
So moving swiftly on to something that doesn't quite move very swiftly. Can we talk about some waiting times?
Yes, indeedy. This is obviously, outside of understaffing, this is probably the thing you hear most about in terms of the NHS being in a crisis. One thing that really stuck out to me, I was working on acute medicine a little while ago. I was rotating there, and there's always lots of pressure once someone is deemed medically optimised. So once they're not immediately going to have a medical issue that causes them to be severely unwell and requiring hospital care, there's a big pressure to get them out of the hospital as quick as possible. And as of July 2023, out of the 100,000 hospital beds in England, 12,000 of them every day are taken up by people who no longer have a medical need to be in hospital.
That's 1 in 8.
Oof.
And when you consider hospital beds costing a minimum several £100s, usually over £1,000 a night.
Yeah. Wow, I really don't like this episode because it's making me think about so many things. So with the beds, not only is it the beds that you have to pay for, but the rooms. Are they shared rooms? Are they individual rooms? And the space that goes for them? And the radiators that need to be in that room? And the sink.
The temperature of the sun.
The water,
gosh,
the nurses, the cleaners,
The biscuits.
the food, the biscuits, the medications.
The biscuits.
There's such a vast cost that comes
Yeah,
alongside
which I've
it.
taken for granted.
The dressings, the scrubs, the cleaning utensils.
Yeah.
What's funny is that Josh has decided this episode is now going to be infinitely long while he lists the whole procurement list of the NHS. The ceiling tiles. But harking back to waiting lists, I think you had a look, Don, at just how many people have been on the waiting list in the NHS in recent years.
Yeah, almost 7 peeps. Almost 7 people.
7 people. There is at least 7 people on the waiting list currently.
God, it's like Perudo all over again. Almost 7 people. Almost. Oh, fuck. Yeah, almost 7 million people were on a waiting list as of 2022. And now in 2025, that is at 6.2 million. So,
It's gone down a little
gone
bit.
down a little bit.
Again, another thing to celebrate. It doesn't seem like much, but we should,
Yeah.
the little wins.
But the times, that's still an issue. So over 170,000 people have been waiting for over a year for treatment. And it looks like I'll be getting there. as
Because
well.
Don and his fractured spine, he still hasn't heard from orthopaedics several months afterwards, and we therefore don't know if it's to be conservatively managed, which it almost certainly is, but the fact they haven't said it is very concerning.
It was our last filming weekend,
It
wasn't
was,
it? That
yeah.
was
It was
quite
a
a while
while
ago.
ago, yeah.
Oh, gosh. We've had several holidays since then.
We have.
National holidays,
Yeah, I was
not
gonna say
actual
not-
holidays, because, I'm a doctor.
I've had no days off since then. No, I've had 1 day off since then.
I've had a really nice long holiday.
Well, lucky for some, eh?
Yeah.
Did you rest your back?
No, I slept on an airbed for 2.5 weeks on an air mattress.
Oh, Jesus.
And kept on waking up basically on the floor as it deflated.
Yeah, and my nieces kept hanging on to me every single morning as they hugged me.
But you were in Australia, so I,
I
have
know.
no
I
sympathy.
was in sunny Australia.
So, obviously, we've mentioned about understaffing, we've mentioned about waiting lists, we've spoken about sort of some of the financial challenges that come with working in the NHS. And so, there's a long-term workforce plan in the NHS. And so, do you want to talk us through maybe, Josh, about what this plan includes and how this might impact the future of the NHS?
Yeah, so they want to double the number of medical school training places, which is really going to help with that bottleneck that I was talking about earlier. So we're going to have even more unemployed doctors. That's a great idea. Yeah, why not do that? Increase the number of GP training places by 50% by 2031 or 32. Yeah, we need more training places. I can't disagree with that. We definitely do. Increase adult nursing training places by 92%.
Yeah.
92%!
So almost doubling the availability of training places for nurses.
Wow.
Within the next 5 years. A poof indeed. It's a steep goal, isn't it?
I just don't see how they're going to manage it, if I'm going to be completely honest. How are they incentivising people to go into nursing? That's the question. They used to have a bursary and everything. They just got rid of it all.
And now you have to work crazy long hours as part of your placements, and you don't
Oh
get
yeah,
paid for
you're
it.
effectively an indentured servant
Yeah.
as a nursing student.
Yeah.
Genuinely, I'm
Yeah.
so glad I wasn't a nurse.
Yeah.
Crikey.
Shout out to all the nurses.
Yeah, thank you for doing
Nursing.
your jobs. Yeah.
Yeah, it's aiming for 22% of all clinical staff to train through apprenticeship routes.
That's interesting. What does that mean, apprenticeship routes? Like what, through what institutions?
So the idea would be that you're associated with a university. I'm just talking about physios, apprenticeships, for example, to start with. And a lot of it transfers over to OTs, nursing, even to doctors. They're actually looking to do medical apprenticeships,
Yeah,
which I don't know how that's going to work. But the idea is that you would start at a non-qualified position. So, for example, as a physio, you would come in as a physiotherapy assistant or a technical instructor, where you have a bit of a background of university training. You then go into a job that you work throughout the course of your degree. So you usually spend about 4 years training, where you're in uni maybe a day or 2 days a week, and the rest of the time you're working on the wards and often rotating between wards, so you're building up that experience. And actually, the number of physio and OT apprentices I've met is very small because it's still very much in its early phases. But the ones I have met are such talented therapists when they become qualified, because they've got 4 years of experience where they've been building towards that, working constantly. Whereas it's with me in my training, it was a 6-week placement here and a 5-week placement there, and you get about 1,100 hours of training, whereas these apprentices are getting thousands and thousands and thousands of hours. So they're way beyond the level that you'd normally get from a student. And also then you start to plug the gaps of, like, you have these apprentices, you have people who can do more of the kind of clerical work if needs be. Their role doesn't necessarily have to be entirely clinical. They can plug some of those gaps that we spoke about earlier. And thinking of apprenticeships, I bloody love the apprenticeship route for physios, because it means that you're getting people who are competent for what they do. Whereas in 2017, the cap for the number of physio students was removed, which now means that universities can take on as many students as they want, which means that they can use them as cash cows, and they give you this spiel about how you're all going to be so desirable and you're going to be batting away NHS trusts. And of the people that I know from my course, I can count on both hands how many have managed to get a job as a physio in the NHS from a course of 70. So that gives you a picture of the fact that we're training too many physio students compared to the number of posts that there are. Whereas apprenticeships that have a guaranteed job at the end, so much better. You get people who are more skilled, they've done a wider range of experiences, they've got more hands-on skills, they've got more understanding of the NHS, and they've got a job at the end.
You've sold it, mate.
You have. I think in most scenarios, I am a big advocate for university apprenticeships as opposed to just degrees. But yeah, I also know a friend of mine who graduated as a physio has...
Is it Joe?
No, he's not a friend. A friend of mine who's graduated as a physio has gone to work in Australia and is loving it. Again, quality of life's better, hours better, pays better.
Yep.
Just go to Australia, Joe.
Just fuck off.
I know.
I'll go as well.
We'll all go.
I would love to.
G'day and welcome to Pine in the Podcast.
Next, you're going to hear my Marlon Brando impression.
Again, listen to the breakdown for that. You might have heard in previous episodes that Josh isn't necessarily the biggest fan of associate positions, but alongside the apprenticeship route, there are goals to try and make more nursing associates and physicians associates.
What else is in the NHS long-term workforce plan?
Well, a big part is trying to retain staff. And so you might have already noticed this if you have family or friends, or if you yourself work in the NHS. There are attempts to make flexible working more possible. There are sort of movements towards high quality leadership, so to speak. This is in a lot of the kind of NHS trust policies of high quality leadership, which makes me worry that they weren't prioritising that beforehand, but I digress. And then health and well-being support as well. There's a particular Instagram account that Josh and I like to send each other messages of their videos of this guy basically mocking NHS emails. And I think there are a lot of these kind of... The attempts at health and well-being, I think, sometimes are a little bit misplaced.
There's a donkey here.
Yeah. There's a donkey in the outpatients department. Come and see it for some de-stress time. It's like, the donkey has carried tuberculosis into the hospital. The hospital will be closed until further notice. You know, it's...
The donkey is on a rampage. Please avoid it at all costs.
I need to see this.
It's, I think health and wellbeing support is obviously important in this plan, but I think it needs to be perhaps considered more. I think there needs to be more engagement with staff asking what they want in terms of health and wellbeing. I know one thing that the trust that I work for does is it gives good access to occupational health physiotherapy appointments, so people who work in the NHS get prioritised access to an appointment if they've got a back problem or if they've injured their ankle or whatever, even if it's unrelated to work. And that's nice, that's a good perk. So that's maybe more the direction we should be aiming in, rather than sound baths, which every NHS trust I work in seems to be advertising like a gong bath. They're like,
what?
This Friday at 6 p.m, come along for a free gong bath. And it's just like...
Why would I want to bathe with other people and gongs?
Does that involve just like loads of gongs around you and you're bathing in like gong sounds?
Yeah. You just lay
or
on
like
your back.
liquid?
No liquid.
Oh,
You just
I
lay on
fully
your
thought
back
liquid.
and they're like, bong, bing,
Well, there you go.
bing, bong. Okay, well, there's definitely one at your trust. If anything that I've worked with...
There can't be. Surely
there
not.
definitely is.
Not in Essex. Actually, yes, definitely. There's several.
But as well, in the NHS long-term workforce plan, one of the big moves is to commit to more CPD funding, continue professional development, which we've already spoken about, and to embrace technological innovation. So things like using AI, working out where it's best to use that, using telehealth, trying to work out whether there can be things like robot-assisted surgery, which might sound a little bit futuristic, but actually...
I do robotic surgery all the time. I don't do the robotic surgery, but in anaesthetics, I anaesthetise patients for robotic surgery. It's quite cool.
Yeah. What sort of robotic surgeries do you see?
Quite a lot of gynecological ones. Yeah. So like hysterectomies and that sort of thing.
Okay.
Yeah.
And so that's the plan in terms of the workforce. What is the more general NHS 10-year plan looking to do then?
So this plan aims to bring services into the community with a focus on prevention, as we said earlier, embracing digital technology to help improve the NHS workforce in its sustainability.
And so what does, speaking about prevention and community services, I know we've briefly touched on this, but what sort of things might that include?
So that can include increasing the remit and or use of community pharmacists, producing neighbourhood health centres. What did you call them earlier, Josh?
Sure start.
Shipja. In every community with at least 12 hours a day, where they're working at least 12 hours a day, 6 days a week. Expanding same-day emergency care services. This is a big one. Banning of tobacco and vapes for young people.
Those young people. Those young whippersnappers.
Targeting junk food advertising, so taking more of a political stance on these. Expansion of free school meals. Expansion of mental health support teams.
Hear me out.
Go on.
Surely all school meals should just be free.
Yeah.
I blame Maggie Thatcher. She stole the milk.
And it was all downhill from there.
It was all downhill from there.
But so that's kind of the prevention and community services. We've already spoken about the digital technology. And so alongside the NHS 10-year plan, what are some potential solutions, so both from within this plan and out with the plan, that could help to resolve some of the crisis issues that we've spoken about today?
Yeah, one good way is increasing accessibility to short and postgraduate training courses, which allows more flexibility and adaptability in training, which can help respond to short-term pressures. For example, graduate entry medicine, the medicine degree I did, which is 4 years instead of 5, but I already had a 3-year degree in science before that, so I'd covered a lot of the scientific basis that we do.
And the same with me, graduate entry physio, 2 years instead of 3.
Hot damn.
And you were graduate psychology.
Yeah. Well, there was more of a conversion, but yeah.
Well, exactly. Yeah, but it's still a postgraduate course to shorten your access to it. So
Exactly. So if you've got experience in a field that's quite closely linked, why shouldn't you be able to just shorten a little bit? I cut out a year of one of the first 2 years, which is like all the scientific knowledge, because I'd already got a degree.
Yeah, in biomedical science, which really, I mean, you
It
couldn't
was
be
essentially
much better
exactly the
prepared
same.
for
Yeah.
the scientific basis of it.
Yeah, and what we can also do is make easier pathways to transition between professions. from like an electronic engineer to a psychologist.
It's quite
or
easy.
potentially more like a nursing associate to a nurse, for
Yeah,
example.
exactly. Yeah.
I know one thing that's been discussed in sort of NHS plans is to make an apprenticeship style final year of medical school. So basically to, in the nicest possible way, have people who aren't yet qualified working as doctors but under supervision, which I know is an element of what you do anyway.
That's effectively what your final year should be.
Yeah. It isn't actually like that though, is it? The
Yeah.
final year. Don't you do quite a lot of exams still, or is that alongside work?
It depends what medical school you go to. Some people do medical school in fourth year. Some people do it in the final year. But final year should be sort of like you're working as a doctor.
Yeah. And you're just using it as like almost a probation year.
Yeah, exactly. Yeah. In the United States, it's a lot more sort of like you're properly working as a doctor in your final year almost.
Yeah.
Is it just me, or did any of the listeners also just get bamboozled by what Josh just said? You only go to medical school in your fourth or final year. I thought the entire thing was medical
Did
school.
I say medical school? I meant, did I say that?
You might have done. I think you meant that you're working in the hospital. That you're
Okay.
doing your final medical exams versus
Right.
being in a hospital.
Right.
Is that...
What I said is you only do your finals in the fourth or fifth year.
No, you said medical school.
Did I?
Yeah. Either way. Well, you know now. Listeners.
Now
We've
yeah.
corrected that. That's good. Thanks, Dom.
No longer bamboozled.
One thing that I think will probably be very unpopular among most people studying healthcare degrees, but I think would be relatively popular with the people in this room. I think there should be a conditionality for people who receive NHS funding as part of their degree. I think that people who receive money from the NHS as part of their training should have to work for a certain amount of time in the NHS prior to leaving. I think that you can, particularly like people like physio, there's a lot of physios who go into it and they're like, oh, you know, I'm just going to go and work in sport, or I'm just going to become a private MSK physio. But actually, like, you're receiving bursaries from the NHS, you should have to do something.
I completely disagree.
Oh, I was wrong.
Wait, so if they were getting bursaries from the NHS, they would have to go work in the NHS. Wouldn't that?
For a time.
Wouldn't there be an abundance of physios then?
Well, I mean, there should be, but...
Oh, right,
you know,
okay.
Like,
There's so many, so that they cause your problems and fix them.
I think there shouldn't be so many taken on in the degree in the first place.
Right,
However,
okay.
the ones that are taken on,
Yeah.
I think should have a
That makes sense, yeah.
should have a due to pay to the NHS.
I agree with that.
So I completely disagree. If I do a degree, I want to be able to move wherever I want. I don't want to have to be an indentured servant to sort of service I don't want to work in.
So selfish. Just, what's
I
wrong
do
with
get
a
what
bit of
you mean, but I think
socialism?
something like 2 years of doing work. So, for example, I know that a friend of mine worked as an OT and she trained in Wales, and there was an agreement that she could sign up to, which was if she worked for 2 years in Wales in the NHS after her degree, they'd pay off her fees. Maybe you could do it like that. Maybe you could do it as an optional.
That's what I was going to suggest is, like, as I said earlier, I've got £112,000 worth of student finance debt. What I would say is, as long as you work in the NHS, that gets paid for.
What, they pay your student debt as long as you're in the NHS?
Exactly.
Yeah.
So you get like a bonus of a few £100s a week.
It's more a happy
month,
medium, isn't
sorry.
it?
Yeah.
Yeah.
And then if
But-
you leave the NHS, then you have to start repaying back whatever your balance is.
Yeah, that's a nice idea, actually.
So it incentivizes
Maybe there's a happy
people.
medium.
Yeah.
Yeah. So what other potential solutions are there then to the issues that we've spoken about?
Come
in
on,
this
we need to completely solve the NHS crisis right
Let's
now.
do it. We could invest in social care.
I've got a house, that's 250 grand. How close are we now? Oh, God!
We could invest in social care, which would help take the load off primary and secondary care and help to support the management of people within the community.
100%. I mean, as Joe was mentioning earlier, 1 in 8 beds are people that are medically fit and waiting to go home. A majority of those are waiting for packages of care.
Yeah.
Like waiting for carers to be established, waiting for handrails to be put up, stair lifts, that sort of thing.
Yeah.
Like, if we had more investment in social care, bam.
Yeah. And community care, interestingly, to get one good health year, so that's like a metric that the NHS uses to see how effective treatments are. If you want one extra year of good health with a public health intervention, so like a community-based intervention, it costs an average of £3,800.
Giving us an example of a public health intervention.
Change for Life.
Yeah.
The diet-based ad campaign and stuff that was looking to help provide advice and support to people who maybe struggle to access high quality diet. So an intervention like that, on average, provides one extra year of good health for about £3,800, whereas NHS interventions on average cost £13,500 for an extra year of good quality life.
God damn.
So actually bringing that care into the community, it can be really beneficial. It feels sometimes, I think, that people think, well, I'm ill, so I should be in hospital. But actually, it's re-educating the population that sometimes the best place to get better is as far away from a hospital as possible, which sounds illogical, but is actually true.
Yeah.
I mean, one thing that could help is an independent workforce planning organisation, which could provide an unbiased view of healthcare needs and could apply pressure to the health ministry. So rather than just all being government sort of data and sort of government ideas, having somebody that's independent and helps to hold the government to account almost on the spending and their planning of the workforce, that could help.
And it would mean that you wouldn't end up getting this thing that we spoke about earlier on of like 5 years of progress and then another government comes and has different priorities and changes everything.
Yeah.
You could have this independent body saying, this is what we need right now. And they could almost make the government in power unpopular. They could lobby and make them unpopular if they weren't meeting the recommendations of this independent body.
BMA.
Effectively, yeah, it would be the equivalent of a union, but not one that
I was
the
about to say
staff are a
BMA
member of.
isn't independent.
Is it not?
Well, no, it's doctors.
No, but that's what I mean. Is if it was,
Oh, I see what you mean.
it's more independent than the government
Of
organisation.
course it is, yeah.
I just thought that would be the closest one.
Yeah. And so to finish off this rather lengthy episode, or part 2 of this rather lengthy double part episode.
We haven't decided yet.
We wanted to give some advice about what you, listener, can do to help the NHS.
Yes, this is where 3 men tell you what to do. So one thing is only go into the A&E if your situation is actually an accident or an emergency. I know it can be tough to gauge that sometimes. But 410,000 people waited more than 12 hours on trolleys in A&E waiting for a hospital bed in 2022 and 2023. And that is an astonishing amount.
And so if you can be a part of speeding the process up for them to get off those hospital trolleys and get into hospital beds,
Yeah.
you know.
There are other options apart from A&E. 111.
Yeah, as I might have mentioned this before, but 111's algorithm is just go to A&E.
Okay.
So not 111.
So maybe not 111 if you live anywhere near Josh.
Use 111, but the majority of the time they do say go to A&E. It's a bit of a joke in the healthcare profession.
You could also, I didn't know this, but you could also volunteer your time and services to the NHS as a receptionist. Didn't know you could do that. A befriender, which is a really lovely role where you just befriend people
yeah.
in care, or a chaplaincy assistant, and there are many more, I'm sure.
Yeah. And
Imagine working for free in the NHS, Joe. Would you do your job without any...
no, I wouldn't do my job for no money, but only because I need to eat. But beyond
you got
that,
loads of yogurts, you're fine. It's too good to go.
it's too good to go. One thing that you definitely can do, that's probably the biggest contribution you as an individual can make, is stay in good health and play an active role in your own healthcare. So if you feel like something is wrong, be proactive and try and seek help early. Try and make sure that you're eating well. Try and make sure you're exercising, that you're getting good sleep. Easier said than done, especially in this stressful world, but you remaining in good health saves the most money to the NHS.
Yeah, I have not done that this past year.
I'm a very bad example of a...
Yeah,
34-year-old
I
man.
just kept letting injuries get worse and worse and not addressing them when I should have addressed them.
Why are my ears ringing?
Also, as well, I think I kind of mentioned this earlier on, give some recognition to the services that are provided by the NHS. Because back in 2022, only 29% of the public said they were satisfied with what the NHS did.
I think that's just the British public, though. We're all
I know,
a bunch of moaning
but-
arseholes, aren't we?
We are. But, you know, there's so much
we're
it
moaning-
does for us.
We moan until we're in a restaurant and then we say, everything is excellent, even if it was just a plate of shit.
I don't. I'll send it back.
Okay.
But generally, yeah.
generally.
I did.
Dom's right.
Was that the last time we went out?
But yeah, you've had your moments.
If it doesn't taste good, it's just like.
See, people hate it when I do it, so I kind of love it when you do it.
Yeah, you take over the role of being the petulant customer,
I'm sorry, but this is just not good enough.
said Josh to West Streeting.
Exactly, yeah, I will. Yeah, so one thing that can help to improve things is if you're a healthcare professional with an audit or innovation that has worked well in your area, then you can share it with colleagues in a wider network.
So one example of this, for example, a big shout out to Kavita Ventukaisen, who is a physiotherapist down south, and she works in stroke rehab, which is the setting where I'm working at the minute. And she basically found a way to increase the amount of physio time that patients were getting threefold by sort of restructuring how the days were run and how the patient timetables were run. And they're seeing really massive improvements in patient function. And so she's very generously sat and had meetings with me explaining how to do this, and I'm trying to introduce these ideas in the hospital where I work. And I'm so grateful to her, because hopefully implementing some of these ideas is going to improve the patient care in the hospital where I work. And then, you know, if it improves in different places, people start to hear about it, word of mouth carries it, and all of a sudden you've, across the country, doubled, tripled, quadrupled the amount of therapy time that these patients are getting. You know, it's well worth sharing. Don't keep your successes to yourself. And also, keeping your successes to yourself makes people not realise the good things that are happening in the NHS. So share, be proud of your contributions.
Yeah. What's it called? Gatekeeping? I really don't like that.
Okay, yeah, well, I think we've covered quite a lot there, haven't we?
Yeah.
What we've talked about staffing, we've talked about costs, we've talked about
Waiting lists and
Waiting
waiting times.
lists. Interventions of how we can change things. Wow.
What you can do as a listener.
We've talked not a lick about chronic pain, but like maybe the chronic pain that is the NHS currently.
Maybe you listening to this episode was chronic pain, but we are glad that you did.
But it does give you a picture, doesn't it? If you're someone living with chronic pain in the NHS, it gives you an idea of maybe why some of these services aren't working in the way that you'd want them to. It gives you that context so you can understand sort of the pressures that the NHS is under.
I think so.
I really like this episode. I think it's quite important. And it definitely gave me a lot of insight into the inner workings of the NHS. So I hope that this reaches the right people. And with that, I'd like to ask you guys to share and subscribe, follow, whatever the thing is that we do now. But yeah, it would be amazing if you could spread this around.
And so to finish off this week, we are going to do our book review, and then we will love you and leave you. So this week we are going to talk about Atomic Habits by James Clear, which is a book that many of you may have heard of. It's a popular self-help book, and it looks at how you can make habits that stick. And so when we're thinking about trying to take better care of your own health, saving money for the NHS, there is no better way than to have a look at this book. It was a 9 out of 10, really fabulous. It has some great strategies for how you can make more meaningful change in a way that doesn't feel so challenging. And we will share a little bit of information about this book and some of the top tips that it gives on our social media.
Indeed. Mm-hmm. And if you'd like to get more involved with Pain in the Podcast, we do have a Patreon. If you'd like to subscribe, please do so. You get to listen to our breakdowns, which is us having a mental breakdown after the episode where we've caused Joe so much work with editing.
It's just me having a breakdown every time.
It is, yeah.
And remembering what we forgot, remembering that we said things that we didn't think we said. Yeah, it's a fun time.
And so much more. So many other pieces of bonus content. So many things that you never thought you would see.
Or if you just want to, you could just do it for 1 month, binge watch everything, and then cancel.
Okay,
mind.
Josh,
that
yes.
would be a whole £3
Yeah.
into the funds to try and pay for petrol so we can keep on recording.
It's one more coffee I can have instead of buying a house.
It's one more avocado I can buy.
So, well, it's goodbye from me.
Ciao.
Arrivederci.